Again, also joining us from Italy is Dr. Luca Gualdi, a very convinced user of our technology, as well as a speaker and a doctor with many publications in the subject of dry eye. He's an anterior segment surgeon at the Doma Eye Clinic in Rome, Italy, and as well as a consultant ophthalmologist at the Vatican City and the American Embassy and other institutions.
Today we're going to discuss a little bit about dry eye and anterior segment surgery. So we're fortunate to have here two great doctors, ophthalmologists from Brazil and Italy. Dr. Luca Gualdi, who is also a part Brazilian. He spent a few years here in Brazil with us, so he's always very supportive to the Brazilian ophthalmology. Luca.
Hi, thank you again for the invitation. Thank you, Petra, Lisa, Riccardo, and Liliana. And here in Italy, there are a lot of people suffering as all around the world about dry eye, especially in those years, last years. And now, as Dr. Liliana said, it's very important to treat the patient before instead of after, because after the surgery, the patient is not very happy. If you don't say before that the patient has dry eye. So it's very important to detect the dry eye before and explain well also in the informed consent that you can have a dry eye after, because the patient after refractive surgery, you can do a perfect surgery not only in LASIK or in PRK or SMILE, also in cataract surgery. You do a perfect biometry. The patient goes to plano and is not happy because says, "Oh, I can see good, but my eyes are not like before the surgery. Before the surgery, I had no itching or pain in the eye, dry eye syndrome." It's very important to detect before. And nowadays, we have a lot of instruments to detect dry eye. As Dr. Liliana said, it's very important that the anamnesis with the patient before start to examine him and ask him if suffer about some pathologies or allergies or maybe some problems with the hormones or drugs or smoke, for instance. And it's very important when you speak with the patient, look at the blinking or ask him if works a lot of computer. Look at the hands, also the hands, because sometimes can have, especially in cataract, can have a problem, rheumatologist problem. And when we do a lot of, you spend a lot of time speaking with the patient before the surgery, before the examination. You go to the slit lamp, and the first thing I think is the lid, because I don't like to do fluorescein just in the starting of the consultant, because if you do fluorescein, you do errors in topography, biometry, and the first thing I do, I see him on the slit lamp, and I go to the exams which detect the examination of dry eye, and I go first with the osmolarity, because I know that if you stress a lot the eye with the light, with the exams, you can have different osmolarity. So the first dry eye examination for me is osmolarity. Then I go to the others. I go to the meibomiography, interferometry, tear meniscus, non-invasive break time, the blinking. I have a machine that makes everything. It's very, very, very good, like the tear check. There are now some machines start to go to a lot of exam in one only machine, and in the few minutes, 10 to 15 minutes, you can have all the exams non-invasive, in a non-invasive way, so without fluorescein or Lisamin green. And then you can do also Lisamin green, you can see the conjunctiva, you can see a lot of things. But it's very important now to detect it without invasivity, because if you think in the past, Dr. Liliana, that works with dry eye before probably me and you, Ricardo, because 2007, it's a lot of time, and probably she used at the starting only Schirmer and breakup time.
Yes.
Now we have a lot of instruments, and you can detect in a non-invasive way very easily. And when you have a dry eye, you can choose if to exclude the patient from refractive surgery or include, but speak a lot before, that can worsening the dry eye. So nowadays we have a lot of also possibility to increase to make it better, this dry eye. So you have the intensive pulsed light, you have the plugs, quantum plugs, you have quantum, I use also the resonance quantic magnecular. It's like a stimulation of the lacrimal gland with a lot of instruments, but it's important to detect before and to treat only also with these instruments and also with the drugs before, and then arrive the patient in your clinic prepared, and you can do the customization with aberrometry, topography, biometry, and you can have also better result, because there are also works which you have better results if the osmolarity is between 280 and 310, while if you have osmolarity more than 330, you can have no good biometry and no good result in customization. So it's very important to have the patient perfect before the surgery to have also better result.
Excellent. In my opinion, is the same. I have some patients that I did topography and biometry before the use of the intensive pulsed light, and after there's a change in the corneal topography and change in the IOL power as well. So this is very important what Luca and Liliana said, because optimizing the ocular surface prior to any surgery is very important. So another topic I think is important to discuss is what is your main treatments when you face a patient with OSD or also MGD, Meibomian gland dysfunction. So what is your first approach to these cases? I know Luca do the osmolarity tests prior to any treatment. I do the same. I think Liliana has the osmolarity pen as well. So so what do you guys do facing this disease, and what is your first treatment, and what do you do as a second option or third option?
Okay, well, the first line of treatment for me is educate the patient about dry eye disease, because it's not easy to convince a patient who is asymptomatic that they have dry eye and they have to take it seriously. They have to take care of the eyelids in a daily routine. That they have to go for a treatment plan, and they have to come to visit us in a regular basis. It's very difficult to to get this compliance from the patient when they are asymptomatic. But when the patients start having symptoms, things change. They start taking care of the eyelids and of the ocular surface because they feel discomfort. So the first line of treatment is educate patient about dry eye disease, about the importance of taking good care of the eyelids and of the ocular surface. Second line for me is the clinical treatment with drops and stimulate the patient with the lid hygiene, warm compresses, a good nutrition, change it in the environment, less screen time, blinking exercises, and also the third step for me would be the EI treatment, the intense regulated pulsed light, which gave me very, very good results in treating these dry eye patients. So of course, Luca had told something about the occlusion of the lacrimal points with plugs. So we have many things that we can do for our patients, like clinically or surgically. We can perform some lid surgery or some conjunctival surgery if it's needed. But I think the main goals is to treat, educate, treat clinically, treat surgically if it's needed, the EI with intense regulated pulsed light, and stimulated daily care and a regular visit to your office.
My experience, there are two kind of patients, two different situations. The first situation is when a patient comes to me for the first consultants and have a problem with dry eye and didn't try with any drops. My first line treatment are drops, for instance. And for instance, omega-3 fatty acids, warm compresses, and cleaning. And I speak about him that there are other options like intensive pulsed light, etc. But when the second option of patients comes to me that already consulted a lot of ophthalmologists or already tried a lot of drops, like also steroids, antibiotics, tetracycline, omega-3, I don't give him other drops option because I do the exams about dry eye and I explain the situation, I educate him, and they say that there are no other options. It depends. The last option is the blood serum and cyclosporine, but that probably not a lot of patients tried before. But I go to intensive pulsed light, regulated pulsed light, because a lot of patients are suffering from meibomian gland disease. And after just the second treatment of intensive regulated pulsed light, they start to be happy. And the more responsive patients are especially those who doesn't have any effect with other drops and doesn't put drops because they know that with drops are not happy. And after just one or two treatments, they start to be happy and very, very grateful for us also. And when I do put-on plugs, I don't put put-on plugs in the first option because I want before to do intensive pulsed light because I want to take away from the lids and the ocular surface the inflammations. Because if you put in, the plugs, you stain the inflammatory interleukins in the ocular surface, and it's not very good. So before you have to make it better the quality of the tear film, and then if there is also not only quality of the lid of the tear, but also a quantity problem, I go for plugs.
Excellent. Yeah, I do the same. So,
yeah.
Oh, sorry.
No, I wanted to. Sorry, go ahead.
No, please, Petra.
No, I would like to hear also to complete, and then I have a question, I think, for all three of you.
Okay.
Okay.
Yeah.
No, just this is very important what Luca said also, because we need to balance the part of the tear film that is aqueous deficiency and also lipid deficiency. We know that the main idea is to first do the correct diagnosis of the disease, see if there's any mixed compound of this, and then in my practice here in Brazil, we do the same. We first start with intensely regulated pulsed light, and then if the patient still have any issue regarding tear production, we add the punctum plugs. Also, we can do 3 or 4 sessions. I think we can discuss this after. 3 or 4 sessions of the intensely regulated pulsed light. But please, Petra, add some information for us as well.
No, it's very interesting to follow your different approaches. And one point, as Dr. Liliana mentioned just in the beginning, you started in 2007 when roughly the first deaths report was launched. Interesting is, and you see today, all of you are very engaged with our device or technology or without. We know that you are the experts and the specialists, and you are confronted in your clinic, in your practice day by day by those patients, as you all mentioned, not happy patient, always maybe claiming, always having pain, always having this itchy situation, and the loss of eye comfort or vision comfort is what we always understand is one of the poorest for a human body, to lose clear vision quality. But if you imagine in 2007, and we had the same experience as you mentioned, 2007, we had still in 2016. I remember very clearly when we first introduced in Europe our technology, most of the doctors at ESWS were asking, what's that? Hey, what's that? What should we do with it? Because it's so rapidly increasing, all these impacts around dry eye. The opportunity, as Luca mentioned, there are today so many different tools also to diagnose. When we entered with first technology to treat, there was honestly not really something dedicated to evaluate dry eye. That means only in these 4 or 5 years, a lot of things happened. And my question would be to all of you, 2007, nobody really took attention to dry eye. Roughly 15 years later, we know dry eye is a real disease, the second most common and very often also linked to the anterior segment with surgery. What do you expect in your clinics, in your practice, will happen in the next 5 to 10 years? How will dry eye be part of your daily practice in the next 5 to 10 years, including, as Luca mentioned, with COVID? Again, I think things changed with the impacts and with the influences creating this disease.
Well, I think for the future, Petra, we are going to have a different situation from now. We have been changing through time. I think diagnosis will be different. I think a combination of tools will give us more sensitivity, more specificity in our diagnosis. I think the diagnosis should be earlier than have this severe dry eye patient. I think we are going to check the tear in every patient in the future. I think it should be our concern, because we are understanding right now the importance of the tear film for our vision and for our outcomes in our surgeries. So I think the diagnosis will be a combination of tools. Maybe we are going to evaluate the glands, the lipid layer, the functional part of the lipid layer. I think we are going to examine the morphology of the meibomian glands, and then we are going to associate it with the osmolarity tests and also with the biomarkers that now are available in Brazil too. So I think diagnosis will go through this way, a combination of tools to get more precision diagnosis, early diagnosis. I think in classification, we will not separate dry eye anymore from aqueous deficiency dry eye and evaporative dry eye. I think we are going to have this mixed forms, this hybrid state of dry eye, and treat the inflammation, which is the underlying situation that we must focus on, the inflammation. What else? I think we are going to screen 100% of our surgical patients. And I think we'll treat 100% of our patients before surgery, dry eye patients before surgery. And talking about treatment, I think it's going to be a combination of treatments too: education, nutrition, clinical treatment, drops, eyelid treatments, the intense regulated pulsate light. I think we are in a new generation of dry eye diagnosis and dry eye treatment. And for me, the take-home message for everybody who is watching us is pay attention to the ocular surface. Dry eye patients will increase all around the world. The digital transformation that we are living right now will lead to ocular surface problems and dry eye. And if you are more prepared, if you know about dry disease, if you study dry eye, if you learn from your patient, it's a learning process. Even for me, that treat dry eye since 2007, it's a learning process for me. So I've been changing all the time, and keep this curiosity in science, in technology. If you are talking about as an entrepreneur, you are in advantage when you have this specific tools to diagnose and treat. But don't give up if you don't have it in your clinic. Start from the beginning and develop yourself in dry eye management.
Yeah, also in my opinion, dry eye screening will become very important, because nowadays there are a lot of patients suffering from dry eye, not only in this period with the mask, with the COVID, which there is an influx of air and increase the dry eye, but also in general, because the people are more in the screening in the computer the whole day, and the blinking is less, so the dry eye is worsening. And people should use probably glasses with blue light protection, and hydratate the eye during the screening of the computer. And also I see a lot of child with dry eye also, because they start to blink a lot. The mother comes to say, my son is blinking a lot, and I ask if they use iPhone, and they say yes, the whole day on the iPhone. And so it's crazy, because also they increase the myopia progression.
How to avoid throwing away your mobile phone, right? It's the best protection towards dry eye.
Yeah, it's very difficult, but yeah.
Will not happen.
Yeah, and also the feeding is changed. Also there are a lot of intolerance in the food. The macrobiota is very important for the people. Also hormones changing, and also for instance allergies are a lot of situations that can increase the dry eye. So I think the dry eye screening will become a tool like normal in maybe not now, but probably in 5-10 years old, or years probably in all the clinic will be present.
Let me add something, Luca. I think the epidemiology of the disease is changing. In the past, I was examining only women, middle-aged women in menopause. They had dry eye, but now I have patients from 13 years old until 90 years old, men and women. So everybody can be affected by dry eye disease, and it's definitely a lifestyle disease. And with our modern life, dry eye patients are increasing, and it will demand dry eye solutions.
Also,
it's important to. Oh, sorry.
No, just also the air is not so pure. The ozone
yes,
hole,
of course.
The ozone hole also. It's a lot of situations.
Yeah, it's important to remember also that's like a myopia boom in the whole world.
Yes.
And these people they use contact lens now at home, and air conditioning and all this environmental issues can lead to increase of dry eye as well. We know that in the past, if you look for a book, dry eye books, like a very thin one. Now, if you read these two reports, it's like a Bible. Yeah, it's huge.
I think everybody.
Also,
go on, Ricardo.
No, just to finish. We think that in the past they think that only in very dry places the patient have dry eye, but we go to Amazon to do some cataract surgeries, and we see patients there in the middle of the forest with dry eyes, and this place is very humid, almost 100% of air humidity. So I think in Brazil we have like there are very lots of countries inside one big country. We have dry places, very humid places, and what we see is a diffusion of the treatment in all these areas. I think in Brazil there are more than 55 EIs installed, including one in Manaus as well, the capital of Amazonas. Yes. Yeah. And I think I just heard from people here in Brazil. I think there are more than 200 doctors treating dry eyes using the intensity regulated pulsed light. And in my opinion, in the future, the treatment will be minimally invasive. So what we do is minimally invasive, except for the very, very bad cases. But I think if you look 10 years ago, when Liliana 15 years ago when Liliana started, it was another world. Now we have excellent diagnostic tools, excellent treatment tools. I think if we continue in this accelerating movement, all the patients will be very happy in the future.
I think not only Brazil, Ricardo, but the whole world is a big market for dry eye, increased number of dry patients, and it's a disease that impacts a lot the quality of vision and the quality of life. So if you are a young patient, I've been treating patients when they are 20 years old, 30 years old. They are very young. They are working a lot in front of the computers. So it affects the productivity, affects financially. Treatments are not cheap, are expensive. The intense regulated pulsed light is still expensive especially for us, for the majority of the Brazilian people. So it's a disease that affects a lot in many aspects.
If I may add one question, because again, interesting, as you mentioned, also you see more and more younger people, children. In which age do you today start treating them linked to dry eye with your experience? Is it 15 plus? Is it 20 plus? What is at the moment the age where you start to see dry eye patients?
Well, my youngest patient was a 15-year-old boy, the youngest that I treated with the intense regulated pulsed light. I didn't have patients under this age, but I do lots of recommendation in decreasing the time in front of the screen, blinking exercises, lid hygiene. Before this age, I think I would prefer a clinical treatment before the EI.
For you, Ricardo?
Yes, the same. So I think mine was around 15 or 16-year-old. It was a boy as well. So yeah, we see now very young people with dry eyes that are affecting their lives. So the treatment should be in an early stage in order to prevent a more severe case in the future.
But the most important thing, Petra, is that this young boy understood his problem. He was spending 16 hours in front of the computers, studying and playing, and with the pandemic, the things got worsened. And the family understood the problem too. So it's very important to involve the patient and involve the family with the compliance, so they will be your partner in the treatment.
Education, as you mentioned.
Yes.
Yeah. The same in Italy, right?
Perfect.
Younger the people. Yeah.
Yeah, a lot of younger people.
Because we just in information, we discussed also a quite similar situation in Canada, and Canada is watching us as well, because and you all are in the young generation, I would say, from the ophthalmologists, and I heard always also looking for what can we do next, what can we do again, improving the support to educate, to prevent, to treat. And one of these projects also was to have a look, or to try also to prevent with regular maintenance, not with a full protocol, but with, for example, with one treatment session per year, to avoid that this young generation becomes severe dry eye case. And of course, I'm here talking, being a manufacturer of this technology, but what we understood based on our studies in a very early stage, when we regarded these neurological papers, that there is an effect if you can stimulate body-owned features, body-owned activities. It's something different than to use drops. And it's because drops is like you take medicine for a headache or something like that. Of course, different, because I know that you have a lot of different opportunities today and much better solutions than a couple of years before. But finally, it's a passive treatment, and for younger generation, in our view, that the longer people wait to start having really a clinical treatment, the more severe the situation will become. Why? Because the influences, the impacts, they are there. That's the lifestyle, as you mentioned, Liana. It's the problem of daily life standard, the modern way how to create life. And people, young children, will not give their mobile phone on site. They will. It's part of our life. It's the same for all of us. So yes, prevention, and that would be my question from my side. What could we do, or what would be your request also to support as part of a manufacturer developing new technologies? How can we support here to provide a solution how to prevent these education features, for example? Because I can imagine it's also time consuming, this education. Time consuming, and you always need to repeat and to repeat to convince to start again. And so yeah, any recommendation you have from your side to our part is very appreciated, because it's part of this whole circle. And it will become, we understood, a much more important part in future to start with this initial first point.
Well, I think if you are in your office, you can, of course, talk to your patient and educate it. I opened a website only about dry eye disease. So I tell my patient, please visit my website and learn more about your disease. So it's a good thing, in my opinion. I show them videos about the treatment, the intense regulated pulsed light, so they understand how the technology works. So it helps me a lot in compliance. And I also film and take pictures of the ocular surface, since I still don't have this mammography. So at the slit lamp, I take photos and I make videos and show to them. So it's part of the education program. And I think with the social media, it's a wonderful opportunity to educate patients about dry eye disease. So I've been talking in my social medias about dry eye disease, and I think people are paying more attention to their symptoms. So, and in your clinic, you can also show videos in your staying room. So everything you can do to educate your patients and your audience, and you can do. So that's the things that I did. I open a website, I'm talking to the social media, to my patients every time about dry eye disease. I don't know, Luca, what you have done.
Yes, I just have a page on my website regarding dry eye, in which there is written everything about the intense regulated pulsed light and all the treatment available in our clinic regarding dry eye. So as is not very common in Rome, a lot of people by internet, they find the intense regulated pulsed light Rome and comes to my clinic because of the web. So it's very important, the web and the education of the patient for dry eye, because they use a lot of computer, and there are a lot of Facebook groups about dry eye, and I see that patients write a lot about their symptoms. They say, "Oh, I was in this doctor, and he gives to me a lot of eye drops, but he didn't resolve. And I went for intensive regulated pulsed light, and now I'm very good." So where do you go for that treatment? And they speak a lot, so it's very important for them to share everything.
Yeah, the information now is very easy to access. So we specialists, we should also add this information to add this to our patients. So sometimes the patients arrive in our clinic ready, like they know everything before they arrive. So
the best case, right?
Yeah, it's amazing. They know more than the doctors.
Yeah.
That's good.
So yeah, so I think we should start our question and answer sessions. So I think we had a first question from Dr. Ingela. Those two treatment steps, do you follow the steps or go directly to step 2, example IPL, or do you recommend direct IPL? Liliana, do you want to answer this?
I'm following the guidelines of the DUCE, the TIFOS DUCE 2. So if I have a mild dry eye patient, first of all, I would treat him with artificial tears, warm compresses, lid hygiene, omega-3 supplements, changes in the environment. And when I have a moderate dry eye patient, so I add other drops to the treatment. It can be steroids or cyclosporine or tacrolimus or antibiotics, systemic antibiotics, and I propose to the patients to go to the EI treatment. So I follow the guidelines, but the majority of my patients are moderate to severe dry eye.
Excellent. So there's another question here. I think this is better for Luca as well. We're always getting to the question, what exactly happening with IPL on the MGD to correct or fix the dryness? Is it about depression, function, stimulation of the nerve? How best to describe it? From Edgar Khalil.
Okay, hi. And IRPL has a lot of functions, because the first function is to remove the symptoms, the dry eye symptoms. But in general, has a lot of action. The first action is warming and liquefying effect. So after second, third, and fourth treatment, the mebum is more liquid and is more easy to express. So you can have as an automated expression during the day. So just after the day after, or in the morning after, or after tomorrow, there is a lot of expression. So sometimes the patient has itching because there is an expression automatically, or you can do the expression, so the squeeze just after the treatment to remove better and in an easy way just after the IRPL. So there is also a photo stimulation there is a photomodulation on the mitochondria, also the meibomian glands, and there is also vascular thrombosis, because there is about the interleukins, the tumor necrosis factor, and prostaglandins, there is a reduction, and the keratinization or the vascularization of the lid it becomes better. So it works a lot for patients, for instance, of rosacea, because the intensive pulsed light was invented by Toyos just on a lot of years ago for patients with rosacea, and he saw that the patient with rosacea treated for the face start to have better dry eye symptoms. So there are a lot of intensive pulsed light, but this is regulated, so it's better because it's selected for the meibomian glands. Also, there is an effect on the bacteria, because the lipases, the enzymes of the secreted by the bacteria are inhibited. And also there is also an antiparasitic effect. So you can treat a lot of patients with Demodex, because Demodex died after the treatment. If the Demodex is especially on the upper lid, I do also microblepharoexfoliation after the treatment, because you can remove it better. And I give also to the patient tea tree oil to remove it better. And also there is also a cognitive rejuvenation of the tissue. And there is also, of course, a neurologic effect, because with the gel is protected the skin, and the intensely regulated pulsed light goes under the skin and on the nerves to regulate better the symptoms of the dry eye. So the effects are a lot, but just to say only in one effect becomes the dry eye is better. But especially works on the qualitative effect of the tear film, but also the symptoms are better after the treatment, so you can increase also the mixed form.
Excellent. Great explanation, Luca. Thank you. Thanks for sharing. Let me see if someone have any other question, please let us know.
I have a question for Luca.
Yes,
okay.
Luca, have you been treating Sjogren's patients with the eye?
I treated 2 or 3 patients, but the effects were not so good, so I stopped, because the Sjogren's syndrome is more hyposecretive than problem on the lipid layer. So I started with other treatments, like resonance quantum molecular, to increase the quantity of the tear film, and then to remove the inflammation, and then with plugs, and then with the last, in these cases, with the intensive pulsed light. They were better symptoms, but no 100% effect like other patients. So the Sjogren, in my experience, are not the best situation for intensity regulated pulsed light. I don't know in your practice.
I have many patients with Sjogren's, and I have treated some of them. I treated that patients who are mixed forms, this hybrid state, and I saw that the patients got better. This is not scientific data. I would love to read a scientific work about dry disease and intensely regulated pulsed light. So I treat some patients with good results, but of course not only the ERPL, but also the clinical treatment and everything, steroids and everything. So I have some patients in Sjogren's disease with good results. The patients got better. That's why I'm asking you, because I think we must have more experience in treating these patients with the EI too. Petra, do you want to say something?
That's exactly what is also for us always exciting. You know, we did clinical studies, of course, to validate in the very early stage the efficiency, the efficacy of the IRPL with the mechanism of action, as Luca explained perfectly, to stimulate, wants to stimulate the gland's function, to regenerate the gland's function, to improve also the secretion of the gland, but in the priority also to stabilize the lipid layer. But on the other side, we had to exclude a lot of different very positive effects. Why? Because you can launch 10, 20, 30 studies, and that's exactly this feedback which we appreciate a lot to hear from the different users, practitioners, specialists, because everybody of you has a different approach and a different, again, niche in dry eye management. We had also from Italy, I remember 2-3 years ago, a doctor who treated a patient with blepharospasm, which was never regarded from our side. And he asked me, do we have a study done on this? No, unfortunately not. But he was so excited about the improvement because it was, he did never expect. And I think there are lots, and that's great. That's something very interesting. Also within our network, Ricardo mentioned that in Brazil there are currently roughly 55, 60 EIs in use, but 200 eye care specialists do use these devices. But it means on the other side, more than 10, 12,000 treatments are done already in this 1.5 years. It's a huge, huge platform on experience. We, from manufacturer developing side, we could never collect as much different feedbacks, especially as you mentioned on the Amazons, where you would never expect that there are so dry eye conditions or very young people. And as we try to support in many different countries and networks, is especially what you mentioned, Liliana, that to see when there are some, even if it's only to regard 10, 15, 20 patients, to have this first feedback. And then we can decide, does it make sense to support here study, to publish something on this issue. The same for the young children, the same for prevention, the same as Luca mentioned, with expression, without expression. What is really the benefit then for the patient? What makes sense? Or what will be dry eye in the next 2-3 years? Do we need other study documents here?
People undergoing glaucoma treatment, they improve a lot with the EI. And also some patients that I treat with neurological disease, such as Parkinson, Alzheimer's disease, they don't blink. And they come to me with a diffuse keratitis. And after the IPL, they improve a lot. So it was amazing for me to observe these patients. So I was very happy that I could improve the symptoms of these patients, neurological patients, glaucoma patients as well.
Yeah, especially those with prostaglandins.
Yes.
Yes, exactly.
Very interesting.
Okay.
Yes.
There is no more.
Okay.
Sorry, Petra.
No, the hour. I just had a look on the watch. It's already 1 hour over. It's quite fast. Very interesting to follow you and your discussion. Really.
Yes, I think it was a very.
Sorry.
Yeah, I think we had a very nice session today. So first, I would like to thank Petra and Lisa for the invitation, and especially our friends Liliana and Luca. It's very nice to see you, everybody very good and well. I think this pandemic moment assures that technology assists us, so we're together far. So I'm very happy to see you all. And I'll pass to Lisa. She's gonna wrap up and finish this session. And thank you again all for the participation, and especially our panelists.
Thank you.
Thank you. Thank you, Dr. Noze. Thank you, everyone. Thank you, Dr. Luca Gualdi, as well as Dr. Liliana Nobrega, for this amazing talk. It was super interesting to hear voices from Brazil, from Italy, and as well on different topics. I know we digressed definitely on the subject, but that goes to show just how many subjects we can talk with dry eye and how we can really, as a team, treat dry eye. And this is why I would like to invite you to also explore our other Connect roundtables, just because we have a multitude of topics that we always can reflect back on. And you can visit www.esw-connect.com to just view the previous roundtables. You can also subscribe to the new ones from there, as well as get speaker insights. And if you have any other questions, you can also contact us at connect@esw-vision.com. And again, thanks again for everyone. Thank you for all the attendees. Stay tuned. Our next Connect Roundtable is planned for end of May, and it's probably going to be for our German-speaking market. Please stay tuned on the ESW-Connect website, and see you all again. Bye. Thank you, everyone.
Bye-bye.
Bye-bye.
Thank you, everybody.
Thank you. Bye.
Thank you for following us.
Bye-bye.
Bye-bye.
Thank you.